And we'd like to welcome you to the best practices for record-taking digital full arch rehabilitation. It is a webinar being presented by our very own Jeff Carlson, CDT, and we will begin shortly. And with that, it is now my pleasure to begin the introduction to Jeff Carlson, CDT. He has extensive experience in both the dental laboratory setting as well as working with dental implant manufacturers in the areas of education, technical, and sales support. He has lectured both nationally and internationally on dental implants. Jeff is the primary author of a 300-page fully illustrated cookbook for restorative doctors and is a co-author of a corresponding restorative manual for auxiliaries that has been distributed in 8 countries. Jeff has also developed a 2-day training program helping clinicians improve their presentation skills, which has been attended by more than 200 dentists from 16 countries. And with that, it is my pleasure to say, take it away, Jeff.
Well, thank you very much, Jessica. And that's all we have time for our program. So welcome and thank you all sincerely. Thank you all so much for joining us this evening. Really looking forward to sharing some tips and pearls. These are going to be the real, when the rubber hits the pavement, so to speak, about record taking. And you're going to find that some of you are already doing all of these things. Others might find some, like I say, some pearls that may help you along. So let's get right into this. I have to give a little disclosure that I am a full-time employee of NDX and Sequence. And so I am compensated as a full-time employee. So what is available for you, there is a PDF that are downloadable from the website that will give you a snapshot, if you will, kind of cliff notes of the record taking. This is just kind of a reminder of the ones that are needed. It gives you just some real high level points as far as things to remember. What I'm going to do is I'm going to dive deeper into those key points now and share some of that with you. So I'm always asked when people want to know about doing immediate full arch, and especially utilizing the digital workflow, is what do I need to do? What do I need to send into a laboratory to do this type of treatment modality? And with at least the system I'll be sharing with you tonight, this protocol, really there's 4 records that are required to submit to get your cases started. And pretty much I'm going to share with you some of the little key points and some tips about how to capture these very accurately. One thing, please keep in mind, when we talk about record taking, that to the degree that the laboratory can provide you with a very predictable outcome, it really needs to have good records. This level of dentistry, it's very challenging when you maybe have had 3 impressions, and we understand this can be hard. Sometimes getting impressions, getting bite registrations. Some patients are just difficult to work with. But please know that we cannot guess at things. If you send in 3 impressions and say, well, pick the one that's best that you choose, that's very challenging for us to do that. So you need to do the best you can to work through that and capture the best one that you can and send that in to us. So let's get started on our record taking. Now, some people think, oh, well, I get these 4 records and that's it, we're off to the races. And quite frankly, that's just a part of it. It's not a complete race yet. So we need to get some more information. So what I really like to do is dive into these 4 concepts and go more in depth with you on that. So let's talk about a very important one. A very important one is photography. And there's really like 5 images that are the minimum that we need to provide you what you're looking for, what your patient is expecting, a very functional and aesthetic appliance. So one of the things that we really want to make sure that we talk about is the high smile line. And when we talk about this, be careful to ask a patient when you're taking a photo to say just smile big. Because patients, as many of you have experienced already, that are accepting this type of treatment, they're not happy with their smiles at all. In fact, they've learned how to do what we call as a guarded smile. So when you say smile big, they can go, smile real big, and they're on their tiptoes, smiling big, and you're not seeing any teeth. So what we really want to see is what we're trying to capture here is the patient's highest position that they can bring their maxillary lip. We need to see in a smile, like an exaggerated smile, because when we do the transition line, the transition line is the delineation between the prosthesis and the alveolar ridge. So it goes from artificial to natural, if you will. And that transition line can definitely make or break a case. So what we've learned is that we want a transition line of the prosthesis to the alveolar ridge to be 3 millimeters above the highest lip line. And so it's very important you get those patients, capture that high lip line, because if not, then when a patient smiles big, and what's going to happen is they are going to smile bigger when they have a beautiful smile and they want to show it off. They are going to smile bigger, and it's terrible when they smile big and their lip gets stuck on top of the prosthesis. So we want to avoid that. But like I say, we've learned that 3 millimeters above the high transition line is critical. So please capture that in your photograph. The other thing is we do want to have the lips parted. It's kind of the low lip line as well. So we're trying to determine incisal length for patients, different age of patients. We also want to show more teeth or less teeth. Also for a man or a woman, we vary that also from an aesthetic perspective. So then we want to have a retracted frontal. So use your expanders, wrong name, to retract your retractors. And so you get a nice frontal shot here. What we're looking for is we're looking at buccal corridors. We also are looking to see the relationship of the anterior teeth, the length of the maxillary centrals over the lower incisors, and sometimes in a class 3. Again, we want to see all this information. What we're looking for is a combination of digital information and analog information. I'll talk more about that when we get into some of the references more into the analog. Then we need to see a right retracted and also a left retracted. And again, what we're looking for here is the patient in occlusion. If they have occlusal rims or a partial occlusal rim, have that in place as well. So what the lab is looking for when they get this information, so we'll be looking at, you say your iOS, you take a digital bite registration. And also sometimes when we're doing our CT scan, they're looking at what kind of occlusion do we have in a CT scan? Does that match the iOS scan? And then also another cross-validation, which is something that is very critical in this type of treatment, is the cross-validation. So we're looking at cross-validation from the photos to models to scans, et cetera. So we want to see this information. We can look at the occlusion here. We can see how a canine is relating in its position as a class 1, class 2, or class 3 position. So again, if we see one record is off, that gives us an opportunity to reach out to you to say, doctor, we're seeing a little variance here. Which way would you like us to go? We really do everything we can to avoid any guessing, because if we either make a mistake, or let's say we allow you to make a mistake by having a record that isn't sufficient, then what can happen, it's not like a context heavy, a crown's high, a margin's open. It could be very detrimental. I mean, we could harm a patient. So this is very important that records are very accurate. So let's talk about impressions. So we have both digital impressions and analog impressions. And I think, as most of you are aware, when you're doing, say, a denture on the edentulous ridge, that it's very challenging to capture a really good static impression, or I should say more of a functional impression, where we see the buccal frenums and labial frenums activated, if you will, so we know where to create the openings in a prosthesis. Now, granted, we're not making a denture, we're making a bridge here. We want to have a screw down smile, so to speak. However, for us to make you a backup denture, which is extremely important to have, especially for those of you that are going into, you're going to do just say an all-on-4, you're going to do 4 implants and in a maxillary arch. I mean, patients are expecting to leave with a screw down smile, if I can use that terminology. They're for sure expecting to leave with a smile, and not having a backup denture and you're not able to load those implants for whatever reason, and they're leaving without teeth, that could be a very difficult conversation for you to have with your patient. So even though the records that we're literally looking for are to fabricate you a fixed prosthesis, we want to be able to make you to fabricate a backup denture. So when you're taking your impressions, when you're doing your scans, think like you're making a denture. In other words, you want to see full extension. You want to see the palatine fovea. We want to see hamular notch. When we're looking from, as we're, on your buccal impressions, again, we want to see the full vestibule area. More anatomy, the better. Now, if you're doing using your iOS technology and you're scanning, which is fine to do, one of the things to keep in mind is that this technology was really developed to record hard tissue. It just happens that it also would give us the image of soft tissue, but sometimes the accuracy is not as definitive as it is when you're looking at, as it captures hard tissues. So one of the things, so we talked about scanning, for a denture, and what happens is when you submit your STL file, the company that you're working with, before they'll submit it to the laboratory, they're going to do what's called trimming the scan. And what that means is they would do this. They would take all that palatal data out, because anything that you see here, any of the imagery, these pixels are data. They takes up information. It slows software down. So what they're going to do is they're going to trim that, because in their mind, you're making a bridge. And so they're going to remove that. Please, when you submit it, say, do not trim the scan. Allow the laboratory to do that. Then we will go in, we'll have an image of the full anatomy that you've captured, and then we'll trim it after the fact, and then we can, make it work a little bit, flow better within the software. The other thing to be aware of is that some of the newer iOS technologies have a feature called artificial intelligence, AI. And with the AI, the challenge is that sometimes the AI will not capture exactly the data that we're looking for. And so it's best to take it off and have you manually do the scanning. And be very careful when you're scanning from the buccal onto the palatal or to the lingual as you're going over the occlusal of the teeth. That is a critical area to capture that scan, especially when we talk a little bit more about the scanning of a bite coming up here. That's an important issue as well. So again, be sure and turn off the artificial intelligence button if you have that option, and scan for full anatomy. So when you're doing the bite registration with your intraoral scanning, that's fine. But one of the things that can happen is, as I mentioned before, when you're scanning, and if you're who's ever doing the scanning, if they're scanning, they do the buccal, and when they go to come over to the lingual or to the palatal, that sometimes if they don't pick up in the right place, there's a little bit of a gap between that. And when that gets stitched together by the software, what can happen is it doesn't make a real accurate stitching, for the lack of a better term. And what it can cause is what's referred to as cast collision. And what you're seeing here, some of you also may have think about this as being like high spots. If you're doing equilibration, well, this is where they're hitting heavy. Well, in cast collision, that literally is two solid objects occupying the same space, which really can't be done other than digitally. So we really recommend, though, look, this patients, they have high expectations. They're spending good money for this, to go ahead and do a physical bite registration as well. That's really for the patients who might have more of a questionable bite. Now, you're going to know that if you would imagine if you had the stone cast in your hands, and you're looking at the wear facets, and you're lining everything up, you go, okay, this is how it goes. Now, rock it here. Yeah, that's there. Okay, there's her bite. Okay, we will not do that. We cannot guess at bite registrations, because that is going to put you and your patient at risk. So we will not do that. So, as much as everyone wants to do digital, the analog really is a nice adjunct, kind of like a belt and suspenders, if you will, but it gives us another opportunity for cross-validation. I really can't stress enough the importance of cross-validation and the advantages of that. When you're doing your CT scans, many times the auxiliary are doing this, but I would really highly suggest that the clinician, you take a look at the scan before it's submitted. When you do have any type of metal in place, watch out for the scatter that can be caused, distortion, blurriness. We cannot work with that. If you're ever wondering about your scan, if the quality is good enough, based on the time of the day and the time zones, we have people available from 6 a.m. Typically on Pacific time until approximately 5 p.m. that could make an evaluation. Now, what we say here, a scan review is nothing more than to say, is the scan a go or no go? This is not a, is this case a good case for this type of treatment? This is only to say, is that scan workable? And that's a scan review that can be done while your patient is still there. So those of you that have patients that travel maybe a couple hours or an hour to your practice, it might be a good idea if you ever have a question to have that as an opportunity to do. When it comes to your setting your CT unit for scanning, different units have some different settings, but what we found that works the best to give us the quality, the best quality, yet still the file's not so large that we cannot manipulate it and work with it within the software. We like to see like as close as you can to a 0.3 voxel resolution. And then 20 seconds for the speed is really, that's the ideal. So keep your numbers close to that and you'll be just fine. And again, please review the scans before dismissing the patient. Now, when it comes to the field of view, there is a minimum really of a field of view that is an 8 by 8 centimeters. More is a little bit better. We used to say 13 centimeters by 13 centimeters as really being the ideal. And so again, if your system allows that, that's nice. Then you can capture the condyles in it. We can start to see more about occlusal planes and how it relates that way. But a 10 by 10 centimeter really is a good target to go for. Now, whether it's 9 by 11, again, settings are different in different units. So you get the idea, I think, because we're trying to capture, that key area. If your system doesn't go to at least an 8 by 8, you're probably going to need to do 2 scans, one focused on the maxillary arch, the second scan focusing on the opposing arch. Now, something that we found too that is very helpful, this serves a multiple purpose, if you will, and that is that taking a hard bite registration does 2 things. One, there's many times where patients are so I see this a lot more with the elderly patients, or it doesn't have to be an elderly patient. If someone's nervous, and what happens is they get in the CT unit, and the assistant's focused on making sure as the unit goes, it doesn't hit their shoulders, their head staying in the right position. Well, what gets missed sometimes is that the patient, I'm going to exaggerate this so you can see it, the patient is kind of shuffling their teeth back and forth. They're a little bit nervous. And you don't catch that during the scan. Well, that's a good way to create distortion, blurriness. So what we found is using a hard bite registration material does 2 things. One, it really helps to keep the patient locked in that position. So if you have a patient like that, I refer to it as a positioning jig, kind of like a scanning positioning jig. You might find that to be helpful for you. The other thing that this bite registration does for us, it acts as a fiduciary marker. So what we mean by that is that when we're looking at cases, especially cases that have a little bit challenging bite registrations, or I should say bite relationships, what you see here in the radiograph images, we can literally go slice by slice through the scan, the CT scan, and we can look to see what the relationship is. Then we can look at the photos. We can look at your iOS scans, again, cross-validation, and we can see if we've got everything lined up properly. We are going to be prefabricating, pre-selecting the multi-unit abutments or the SRA abutments based on what implant systems you're working with. We're going to pre-cut the temporary sleeves, the temporary copings. We're going to create blackout plugs. We basically have done the case prior to it arriving into your office. So the implants are placed on the model, all set with the proper timing, the depth of the implants, all controlled in surgical guides. So these records are really important because we're going to go off of this and create you, really help to minimize a lot of variables that you would typically find when you're doing it either free-handed or even if you're using guided surgery, but when you're coming to a conventional completion for the final prosthesis, it can help to really minimize a lot of those restorative appointments. So again, that hard registration bite material, most of them today are pretty radio opaque, and this is what the purpose for that is. So when scanning, when we do have a bite registration, we find it's probably best really to scan with the bite in place, use the chin rest versus the bite fork. That way we can have, we're able to relate the arches a little bit better. So we really prefer not to have the bite fork utilized, so use the chin rest for that. When it comes to your edentulous cases, patients, we're doing what's called a dual scan protocol. And to do that, we need some radiographic markers placed. And what we found is we'd like to see 6 scan markers, radiographic markers. And we want to see 3 on the palatal lingual area, and then 3 on the buccal. And what I wanted to point out to you, so what you're seeing here, this particular scan marker that we're utilizing, these are Suremark utilized in this photograph. They're a sticker that has the radiographic bead is right here in the center. And you like to keep those pretty close to the neck of the teeth as you're placing those scan markers. Place 3 out on the buccal, place 3 into the palatal area or the lingual area. And what you want to avoid is having one directly opposing the other. In other words, if you're on the second bite, as you see here, we've got one in the palatal set. Don't put one directly on the buccal at that same position. It's hard to match up in the DICOM file. When we open up your zip drive and we have your STL files, we have the DICOM files. It's basically 3 points of references that we capture to triangulate and to line up these images. So we need to be able to identify each radiographic identifier so that we can grab that and line things up. I hope that makes sense. The other thing that's nice is what you're seeing here in this image with the denture tooth with this blue on it. This is a marker, a sticker. It's kind of like a breathe right strip. And this will actually give the laboratory a beautiful reference, as you see in the scan here, of exactly where the facial of that tooth is, the incisal ledge. So we have hard reference points, if you will, between the alveolar ridge and the patient's existing denture. So you can communicate to the laboratory if you'd like the teeth 2 millimeters longer, or 1.5 millimeters longer, you want it more facially by 1 millimeter, or bring them back a little bit. There is we know exactly when you say whatever measurement you give us, we have very accurate reference points to make that a really smooth transition and really spot on, get that tooth in the right position for you. So this is something that we kind of recommend using and are very helpful to do. So when we get into the dual scan protocol, we're going to be scanning the patient with the prosthesis with their denture in place with the scan markers. You do that scan. Then you're going to remove the prosthesis, the denture, and we want to scan that. What I'm showing here in this image is that when you have this particular case, they used just a clear denture duplicate. We don't want the bite registration on the prosthesis when you're scanning. And I'm going to show you in the next slide because we're actually going to scan this separately on a box and scan it with your CT unit. So what I wanted to show you though here is if you notice this more opaque color right here, this represents the soft line material. You don't have to do a hard reline on a patient's denture. It's not a bad idea to do that. But again, this denture is short-lived for this patient. Most clinicians, they're just going to take a PVS impression. Light body is fine, probably not much more than a medium body. But what you're seeing here is that more opaque area. That is how much that this denture needed to be relined. And so when we're scanning, we want to be able to, when you scan the prosthesis, we want to have that as accurate here on the prosthesis as we do on the ridge. So just keep in mind, it's probably a good idea on a denture to do a wash. You don't have to do tray adhesives. Just, clean out the fix-a-dent and forget it. And then do a wash impression. And if you don't want to leave it in there, you can just peel it out right away and load it back up with their fix-a-dent material, whatever product they're using to stick their denture in place. The other thing, if you're doing a dual arch, do not stack your rims or your dentures together. We want a separate scan of each arch of the prosthesis that you're scanning. It's just too difficult to try to separate that. So what we prefer seeing you do is to take, so if you're doing a dual, this was just a box, and I think this particular clinician put a little foam block on it. So you got to get a box, prop it up as if it was the patient's head within the unit. And it doesn't matter if the incisal edges are down or up. Scan the upper denture, scan the lower denture. If you have a wide enough field of view, you can set them next to each other, as long as they're not on top of each other, and scan them that way. The other option we're showing here, if you didn't have the scan markers, is kind of more the way we've done it for many years, radiographic markers. Sometimes people put a little BB in there. Others might use a little gutta percha. That's still your preference, but we do find that these scan mark stickers work quite nicely. All right, so that's a bit about the scanning. The other thing I want to talk to you about on record taking is about capturing the proper VDO, vertical dimension of occlusion. We see a lot of clinicians, since we're edentulating an arch, they are trying to put their patients into a CR/CO position. That really is up to you of what you're trying to accomplish. I use a reference here, MIP, which stands for maximum intercuspation position. So that could be, people could say, oh, it's my CO, it might be COCR. So what we're really looking for here, as you see on our image here, when you have a case where the patient is edentulous in one or more quadrants, here we see him edentulous in opposing quadrants. This is one of those cases that we need to have a vertical stop posteriorly. We will not guess it. We just can't do that. If we make a mistake, you could be putting an implant either into a sinus, coming out a buccolingual plate, into a nerve. So it's very important that you're capturing very accurate records. So in this scenario, what we're going to ask for would be, and request, would be an occlusal rim. And if it was maybe just one quadrant, some people will take and use like a putty, bite registration putty, and use the putty as a rim, so to speak, as an occlusal rim. That's fine. But if there's any question of how it's going to fit on the alveolar ridge, we're not going to guess. So just keep that in mind. If you're guessing how it might be in the mouth and how it fits in the mouth, if you're guessing, don't do it, because we won't guess. You're going to get it kicked back and you're going to have to do it again. So, and that's not being arrogant. It's us knowing what works and what doesn't work. So in this scenario, we were edentulous in these two quadrants. So occlusal rims were made. Now, the other thing is, I mentioned earlier about the markers, is we want 3 reference points. So here what we're doing is you're seeing a scan marker placed on the buccal because we have a whole quadrant edentulous. So let's assume on the other side, the left side, that we can't really see here, the patient has dentition. So a reference point for triangulating it, here's 1 is the marker, 2 could be the facial of the central and incisal edge, 3 could be a molar or a second bi on the other side of natural dentition. So, but I think the best thing is, when in doubt, add a marker. If you're not sure, put a marker in. It's not going to cause any harm. And that way we're not sending anything back to you. So just again, occlusal rims very often are needed on these cases. Now, one thing I want to point out is if you are using just like patient does not have an existing denture and you are literally maybe using occlusal rims to scan with, it's a great idea to, mark that high lip line, mark the midline, give us some more information. If it's a wax try-in you're scanning, make sure even on there, go ahead and mark that high lip line. But what's very important, very, very important that you catch this that I'm about to say, and that is that when from the vertical dimension of occlusion that you've captured in your CT scan, we cannot open or close your vertical any more than 3 millimeters, and that's 3 millimeters in the anterior. So we're really talking about only opening up posteriorly about 1 millimeter. And the reason for that is because software doesn't really have a true arc of closure to open bites. It's more of just straight up and down. And we know from experience that if we do more than 3 millimeters in the anterior, that now the trajectory of the implant placement has a propensity of being off. And again, implants going, well, we're not planning them to go. And as many of you know that have done these cases, many times we have really narrow ridges and we're really precisely trying to squeeze an implant in there. So it has to be really spot on. If you need to open it more than 3 millimeters, you need to do that in the scan. Maybe you're using a splint to do that. Maybe using a leaf gauge to do that. But just keep in mind that when you're doing your scans, scan them as close to the ideal vertical dimension of occlusion and the MIP or the CO-CR relationship. So now you have this data that you've captured, and to submit it, if you're working within Sequence, most implant companies are going to have a pretty intuitive way to go to their website, download it, I should say upload it onto their website. Again, there's just your kind of a quick references of the key things that you're going to be loading. These files, your STL files, your DICOM files, they're all going to need to be compressed into what's called a zip file. And again, when you go to the website, you would see how it explain how to do that. It's a nice tutorial for doing that. We're not going to cover that during this presentation. So now that we've got all this information, what are we doing with this information? And so what's going to happen, and this surprises people, people keep talking about digital workflow. This level of technology that we're dealing with in this treatment modality, I should say, the level of treatment modality, that to be as accurate as we need to be, we really need to work in both an analog world and a digital world. So if you send in digital records to us, everything's digital from your perspective. When it comes to us, we're going to print models, we're going to print bytes. And so we're going to take digital and turn it into analog. If you send in a byte, you send an impression, you send in a model, we're going to scan your analog information and we're going to turn it into digital. Again, it's that cross-validation, cross-referencing that it's very time consuming, but to deliver what you're expecting and your patient expecting, that's what's needed here. And I think that's what many clinicians really appreciate when they're working with the system of really how well things literally do fit together. So we're going to digitize, as I mentioned, any of your analog data. Then it goes into segmentation, which segmentation is delineating between soft tissue and hard tissue. So that takes time. We go slice by slice. So it takes quite a bit, almost 45 minutes to do one arch of the segmentation. Then we're also going to send the case to the smile design department. Then based on your prescription, based on the photos, let us know if you want, more of a feminine arrangement, size, if you want teeth larger, smaller. Again, we're just a temporary that we're making at this stage, but this is a good point to communicate that with us. So our smile design department then is going to create that new smile for your patient. And then it'll go into the actual design department or treatment planning department, where they're going to go ahead and, prior to having your online meeting, our design technicians are going to place all the implants. They're very trained on understanding about biomechanics, understanding AP spreads, about having enough vascularity, enough bone width, So there is enough vascularity to regenerate bone cells for integration to occur. So they're going to, based on the implant system you've indicated, that then they're going to place the implants in, lay it all out. Now, some of you may ask for 4 implants, and at the go-to meeting, you may see 5 on there. Well, there's a reason for doing that, and that's because we're also able to determine bone quality through the scan. And so when we see that this patient has maybe like really a lot of D4 bone, we're going to make a suggestion for a 5th implant. We do not charge any more for 5 implants, 8 implants, 4 implants. It's all the same price. There's just more components that are involved. So it's not like we're trying to upsell you by putting in more implants. You know, this is what we do, and this is all we do. And so we're trying to make this case, set this up for long-term success for you and your patients. So now we've got the treatment planning that we've laid everything out. We're preparing for the online meeting. And so we'll take all that data, get everything in a case pan. You'll get an email to say, okay, here's a calendar, pick out your time for your go-to meeting. I'm sorry, your online meeting. And so what's going to happen at this point, and this you do at the comfort of whether it's your home, wherever you want to do it. If you're a specialist, you can have your restorative doctor on the call with you. You can have your assistants, you can have your lab tech. This is open to anyone that you also want to invite to this call. And so what they're going to do, our design technicians, they're going to show you, sometimes they'll start with showing the bite. They'll say, doctor, this is what we came up with. Does this look like what you anticipated, what you saw in the mouth? And if nothing's not looking quite right, be sure and say something. I just kind of want to fast forward this up to this point right here. This is a very important one. I'm going to pause this for a moment. So if you have an anticipation, your patient has an expectation of how they want their new smile. What you're seeing in this image here is obviously the brown is their existing dentition, and the white is where we're going to make their new smile to. And so if you were anticipating the teeth to be, in this particular case, maybe a little bit more palatal than what their existing dentition is, then you could say that looks right. You know, we're almost a full tooth in to a degree here. If you wanted a midline shifted, you didn't see it here. This is all in our design so far. So we're not committed to anything. If you see something, please say something. And so this is very important for the restorative doctors, that for you specialists have restorative doctors on there, call them out on it. Say, you know, Dr. Jones, is this what you're looking for? You know, are you happy with that? So this is your opportunity to kind of have a little aesthetic visual verification or validation at this stage. So then they're going to talk also, they're going to get into showing you about the bone cut. So there is a minimum amount of interarch space that's required for the different final prosthesis based on what you've selected. So what we do as a default, when we're determining the interarch space, we're going to go 15 millimeters from the incisal edge of your anteriors. I'm going to pause that for just a moment. 15 millimeters from the incisal edge to the bone cut, which would also be the platform of the implant typically. Some of you might like to bury your implants a little bit more, that's fine. But what we're doing when this 15 millimeters is from bone cut to the incisal edge of the occlusal plane, 15 to 16 in the anterior, and then 14 in the posterior. Now, if you're doing a zirconia type of a prosthesis, now we can go with less bone cut. We can have less interarch space. The previous 15, let's say 15 to 14 millimeters, maybe tapering it down to not much less than 13 in the posterior. That's going to be for your titanium bars with a wraparound acrylic and denture teeth, your kind of conventional hybrid, if you will. If you're going to get into a nano ceramic, we're looking at about 13 millimeters as being our minimum. When you get into the zirconia, we're going to go 12 millimeters of interarch space. So as we're looking here, we're showing you right here the bone cut for this particular patient. And this is what we come up with. Now, if you're not, and then they'll pull down little measuring tools and tell you how much that is. And if you have any, concerns about that, This is a time you bring it up, talk about it. They're going to talk about pros and cons. If you want more bone cut, we're going to look at, sometimes you want more in the anterior bone cut. We have to keep that bone cut going continuous posteriorly to kind of fade off, if you will. We're going to look at the sinus. So we might bring up to you a doctor and we'll show you, we'll come over here and refer to where the sinus is. And again, it's your call on anything that we bring up or suggest, whether we go forward or not. You're in charge. We're just showing you what we've ideally designed from what we know, and then we'll modify it to meet your needs. So you don't have to buy any software, learn how to work with any software. And then we're also now, after we talked about the bone cut, and again, it doesn't always happen in this exact sequence, but you're going to get all this information on that meeting. Then they're going to go implant by implant. They're going to show you where we place it. They'll talk about angulation. You'll see the orange here would represent your multi-unit abutment. Obviously, your implant in green. The pink is the bridge portion of the prosthesis, and white would be outlined there is the teeth. Do notice that the blue represents, that's where the bone, so that you might see it there. You can see it real good here. That's after bone cut. So we're showing you this particular clinician wanted their implant a little subcrestal from the bone cut, and that's fine. Again, you have total call and decision on that. So they're going to take you implant by implant and show you how that, each implant site. We also can literally could click on a button and be able to show you bone density in that area as well. Okay. So that's your online meeting. And so if you as a specialist agree to the design, the implant placement, the length of implants, size of implants, all that can be changed almost like in real time. These people are very talented. They can manipulate those images very quickly for you. Most of these online meetings, your first one, plan 20 to 30 minutes for a single arch. Once we get to know you better and you're comfortable with it, many of our clinicians are doing these meetings in 10 minutes. Some are even saying, just send me some scan images of what you came up with, and I'll just approve it on my phone even. So you don't necessarily have to have a go-to meeting. So that's not where you start off with. That's where you can go to, okay? So we've had our meeting and everyone's approved it. So then we're looking at when can you get all your surgical guides, the prosthesis, temporary prosthesis. So we're looking at typically 11 to 15 working days from the time that the meeting has been completed. On your meeting, they will tell you, based upon our schedule, they'll tell you at that time when the case will be delivered in your office. So please, I really suggest you don't schedule patients' surgery dates, especially if you're bringing in an anesthesiologist. Don't schedule that ahead of time until you've had these meetings, because then you're going to have to maybe mess with other people's schedule, including your own, if we're not able to do that. We asked for this time frame because it takes a lot of effort, and there's quite a team to put all this together and to make it happen for you and your patients. The other thing is, very importantly, especially for those of you that live in our wintry states, from Minneapolis, getting snow quite a bit this winter, you don't want to schedule your patient so the day after is supposed to arrive. So if someone, our design planner technician, tells you that the case is going to arrive on Monday the 13th, don't schedule the patient on Tuesday the 14th. You want to give yourself at least 3 to 4 days. One, things happen. FedEx might get a flat tire, planes, things happen, mechanical issues, weather. The other thing is, you have the opportunity to do what's called a dry model review, where you could literally take these models, put it on the articulator, and evaluate it. You could get your surgical kit out, make sure all your drills are fitting through the guide properly. And then what's really good about doing that is if you find out that you don't have the right driver, you don't have a short driver, you don't have a long driver to remove these screws in and out, you have time to order one. So again, this is a very important thing to do, is to plan accordingly. The other thing, on our website, under education, on a drop down here, we have what's called a virtual learning academy. And these are a lot of PowerPoints. Some of them are narrated, and some of them you actually get CE credits for as well. This one that's highlighted is best practices for record taking, which is a little bit, goes more into detail. All right, pretty much repeats, I should say, the information I'm sharing with you. But there's a lot of other information that's really good there for you to review. Also, there's resources for restorative doctors, those PDFs on record taking, that's located in that area. It's also located in the surgeon's area. So a lot of good information there for you. So at this point, I would like to say I went through a lot of information fast and really appreciate your attention. Stay healthy all, and peace.